don't we get started? And I just wanted to welcome everybody to the Spring Learning Collaborative of Greater Health Now. It's been a while since we've had one, so we wanted to get this going for 2024. My name is Patrick Jones. I've been your facilitator at Greater Health Now for a few years, and it's been my joy to do this both in person and now virtually. So today, as you've seen, it's all about healthcare workforce and all the different dimensions that come with that question, certainly for Greater Health Now and in part for the state of Washington. We've got 4 speakers, including yourself, including myself, and I'm going to turn it over to Nicole Matthews at Greater Health Now to sort of give us a bit more detailed lay of the land. So Nicole, could you start us out, please?
Absolutely. Good morning. And Patrick, we are so glad you were here facilitating because this is not new for you. This is a very near and dear subject to us. Yes, learning collaboratives are important to Greater Health Now, not only for convening, information sharing, but to also inform the work that we do. And workforce development, absolutely. In shaping, transforming systems, we have significant investment that we need to do in workforce development, not only for us at Greater Health Now, but for our region. Some housekeeping. If you need to go use the restroom, please go find your own. If you guys have questions at any point in time, please type them in the chat. We do have quite a bit of wonderful speakers here today. We might always have time for interruptions, but I'll keep an eye on the chat. So if you have questions, either save them to the end or write them in the chat and I will keep track. We're here, glad you're here. If you can enter your name, organization affiliation, and then your email if you want to hear about any other resources or continue learning collaborative or any other events that we might come up in the future. So, and at the end, we're going to kind of wrap up and touch base a little bit what Greater Health Now is doing as far as our investment in workforce development and some of our other activities and initiatives coming up. How's that sound, Patrick?
That sounds good. So do you want to go over what we hope to gain from today's session?
Absolutely.
Or is that Danny? You or Danny?
I can totally. Danny's a wonderful speaker. If she was comfortable, I would have her do it. She's the one who was able to gather all this for us. So Danny, do you mind or do you want me to continue?
Sure, I can go over these. So thank you all for being here. We spent a little bit of time putting together some learning outcomes for what we hope to achieve today. I will let you read through those yourselves. I don't need to read through them for you, but the big goal is to dig down into the health workforce data and initiatives that we have going on across the region. We're going to learn about the Sentinel Network and some of the work that we're doing. And these are our takeaways for today.
All right, thank you, Danny. Why don't we just move into the session then? You ready, Nicole?
There we go.
Okay, so whatsoever lightly, you see that we have 4 presentations. It's not common that the facilitator does a presentation, but I do double duty at Greater Health Now in actually doing data analysis. I'm going to present sort of a big macro picture of the 9 counties that might pertain to the healthcare workforce. Ben Stubbs from the University of Washington is going to join us to talk about the Sentinel Network, all the good work that's been going on for several years along those lines. Ben will be followed by Renee Fullerton of the Workforce Training and Education Coordinating Board. That's a mouthful, Renee. With an update about what's going on there. And we will end the presentations from Louis Cepeda from WASAC. Lots of initiatives, excuse me, taking place with that group as well. We have allotted about 25 minutes for Q&A, and we don't have to take all that if there's no questions, but we certainly hope that there will be questions that you'll have throughout the course of the presentations. And I'll just say For me, in my presentation, if you have a question or two at the end, there'll be time for that. And as Nicole then mentioned, we'll wrap up with a little report out from the staff at Greater Health Now. So why don't we get started? And I'm not running my own show here. It's Danny or Nicole, I think. So here's my presentation looking at demographic, economic, and education, basically upstream measures for the healthcare workforce. Next slide, please. So I run a shop, research shop at the downtown Spokane campus of Eastern Washington University called the Institute for Public Policy and Economic Analysis. Another mouthful. I just shorten it to the Institute. And we do quite a bit of data work and contract analysis. And I've been with Greater Health Now almost from the inception, going back to 2014 in a variety of capacities. So next slide, please. Most of the information I'm going to share with you today, it's data, come from large data portal projects we have throughout Eastern Washington and one in Western Washington, which we won't do. But if you just look at the map, you'll see that for the 9 Greater Health Now counties, we have Yakima, Benton, Franklin, Walla Walla, and as of yesterday, Whitman officially launched. And then we also have in some of our Walla Walla project, Columbia County data. So we cover most of the waterfront of Greater Health Now. Our apologies to Southeast Washington in particular, and to Kittitas, where we don't have projects. Next slide, please. So I think we need to look at one slide before that. I think we skipped a slide. Oh, we should have one on population. That didn't show up. Okay. Okay, well, we had, could you go to the next slide? I just want to make sure that didn't get out of order. And next slide. Okay, back up. We're missing a couple of slides, and I'm going to wave my hands and just tell you
travel across 24
that population really drives so much of healthcare workforce and any workforce consideration. And I had a couple of slides on that. I'll just say that, oops, what happened to the slides? Nicole, could
It is not. It's Danny driving this. I think she's making sure she has
Okay.
it.
it's
I see
slide
it there.
it's slide 8, if you wouldn't mind.
It looks like I got an X through it, but I see it.
Okay, thank you. So currently the population of the 9 counties is 765,000 people. That's a gain of 100,000 people in the last 12 years, which is pretty dramatic. And I'm just with a dash line indicator what the forecast is from the state, about another 55,000 between 2023 and 2030. So that will have strong implications for the healthcare workforce. And I'll just say right now that as we look at job openings in any given discipline and any given occupation, the smallest amount, which the 55,000 represent, is due to growth. And actually, you can compound that job openings due to growth via retirements and people changing occupations. So just put this 55,000 gain implicitly on steroids to get to a forecast for the healthcare workforce, which I am not providing. Okay, next slide, please. So a key component in demographics is age, and I'll just make this claim right here. And if people want to ask questions about that, we can in the later on. But a younger population actually requires less care than an older population. And looking at the age structure of all 9 counties, in this case, of Greater Health Now versus Washington, you'll see that Greater Health Now's population is disproportionately tilted young. We have a lot of children ages 0 to 19, children and teens compared to the state, and a bit more in the 20 to 29 age group. Correspondingly, then fewer in the adult, if you will, prime adult and older adult categories. So that has implications for demand for healthcare and therefore demand for healthcare workforce. Next slide, please. And it wouldn't be right to ignore the fact that there's a lot of variation among the 9 counties. And if you can look at counties 1, 3, and 5, going left to right, that's Asotin, Columbia, and Garfield, you'll see that that gold bar at the top of this age distribution depiction these gold bars are quite large. In other words, they have more than 1/5 of their population in the 65 plus category, whereas Franklin and Yakima counties, so 4th and the one on the far right, have large blue bars, indicating just how strong the youth population is in those communities. And then finally, for the college, what I call college communities, college counties, Kittitas and Whitman, you have those orange bars that are disproportionately large. So there's a lot of variation with what I just showed you about the overall age distribution, but generally it's young. Next slide, please. And it is in some cases much more diverse than the state of Washington. That you can see the dotted line there by the state. People of color is 37% as of an average of 2018 through 2022. Most of the counties have a share of people of color below that 37%. However, Franklin and Yakima counties are way above that. So I think we understand that we all implicitly know that that is due, Franklin and Yakima counties, due to the presence of the Latinx population. But I think this points out that in certain counties, there's a real strong need for culturally competent care in the workforce. Just leave it at that. Next slide, please. Another demand factor is the Medicaid eligible population, which is somewhat equivalent to the lowest quintile, actually a little more than the lowest quintile by income population. And I couldn't find a more recent number of Medicaid eligible in Greater Health Now than a 2020 report from the HCA, and I hope that there's somebody online from the HCA and you can tell me that there's a 2023 number, but what we found was 237,000, and recall that the total population in the Greater Health Now in 2023 was 765,000. So this is a significant part of the population that is Medicaid eligible, and of course then in the purview of the work done by Greater Health Now. So I'll just point out the final bullet that if you're a provider and you look at Medicaid only, or if you look at Medicaid payment levels, typically that's a problem unless you're set up like an FQHC that largely deals with the Medicaid population. So that will have some impact on healthcare workforce as well if a large and perhaps growing part of the population is covered by Medicaid. And the graph shows just the number of Medicaid eligible lives in the bars, and then shows the rate compared to the total population. And you can see it's really led by Yakima, and then Benton County by totals, and then by Yakima and Franklin County by shares of the population, 41% and 35% of the population. So another factor. Next slide, please. Income is highly associated with more care in national studies. And where does income land in the Greater Health Now area? Actually quite a bit below the state median household income, which is that green bar on the right, or green line on the right, which you see is about 90,000. Every single county in Greater Health Now has median household income below the state median. The one closest to the state is Benton County, and in fact, Benton County has income higher than the US median. But in general, incomes in Greater Health Now are low, and this will have, in my opinion, some dampening effect on healthcare utilization and therefore workforce. Next slide, please. I'm going to summarize just the demand factors, and I think I'm doing okay in time, so this is great. So population is expected to increase between 2023 and 2030, about 7%, which is a little bit less than the state of Washington's overall forecast, which may have surprised people. There are some differences there as well, which I didn't get into. Tri-Cities is growing much faster than that, and Southeast Washington growing much more slowly than that. The population of the 9 counties is considerably younger than Washington. That's largely due to a very large share of young people in most of the counties, but not Southeast Washington. Overall, the population is less diverse. However, Franklin and Yakima counties are the exception. There is a higher Medicaid eligible population than Washington in a couple of the big counties, Franklin and Yakima, and that statewide average was 27%, by the way. And then outside of one county, income is in the 9 counties is quite a bit lower than the state as measured by median household income. So those are sort of those determinants that pull on the demand side for the healthcare workforce. And I'm going to show a little bit about the next slide, please. Healthcare workforce supply. What drives the supply of any workforce, in particular healthcare workforce, and then end up with a little quick view of the relative strength of the healthcare workforce in the 9 counties. So just backing up, looking at the overall economy of the 9 counties and looking at the shares of the workforce in the 9 counties in 2022, there's about 19 sectors, and I highlighted the 7 largest here, ranked them left to right. And you can see that government is the highest, and among the top 7, construction is the smallest. And healthcare in the gray bar pops up as the 3rd largest, almost as large as the 2nd largest, which is agriculture. So currently there's about a little shy of 45,000 employed in the healthcare and social assistance sector. That's 2022. We'll get the 2023 numbers in about a month, and I expect these will go up in absolute numbers and also percentages, maybe slightly to, my guess would be to 14.5%. And if you fold in public hospitals and take their payrolls from that government sector for a few of the counties, healthcare and social assistance in Greater Health Now is already probably 14.5%. So that implication is 1 out of every 7 jobs in the 9 counties are in the area of healthcare and social assistance. So a very significant part of the local economy. So next slide, please. This may surprise you, but it's very clear as we've been tracking for our different trends projects that the overall workforce in almost all the counties we cover has not attained the levels we saw pre-pandemic. So I have added up what we call the workforce, and workforce are people with a job and people looking for a job, adding those two together. And you can see that for 2019 and 2023 on this graph that that the 2023 number is still about 1,500 positions or people lower than 2019, start of the pandemic, or just before the start of the pandemic. And so generally I would say that's a challenge to Greater Health Now's workforce in general. It's hard to have a growing healthcare workforce if the general workforce is shrinking, and that's what we see. In fact, if you look at the difference between 2022 and 2023, it's negative. The healthcare workforce in 2023 slipped. So just keep that in mind. There's lots of reasons for this. Something called the Great Resignation, boomers like me deciding now is the time, we're getting out of the workforce. And then there's just this question of, are we engaging certain pockets of the population as well as we have, such as people with certain disabilities, people who are immigrants, and people who are less than 21. And we do have, Kyle, we do have county-specific healthcare workforce data. No problem. We can get that to you. Next slide, please. Okay, so I'm then going to show you where Greater Health Now is in most of the counties via a measure of concentration. In other words, we're trying to say how deep is the employment in the healthcare workforce sector compared to the state of Washington, you'll see in this case. And we do this through this location quotient method. It's just a very simple ratio of ratios. At the top, we have the percentage of the healthcare workforce in any given county or any given area. In this case, it's going to be Greater Health Now. So that's the number of healthcare workers relative to all the workers in Greater Health Now. And we're going to compare that same ratio to a similar ratio, in this case, in the state of Washington. Very often this is done for the US, but I'm doing it for the state of Washington to give us a sense of how does Greater Health Now compare to Washington as a whole. So the way to interpret the numbers that come out of this are, if it's greater than 1, if the location quotient is greater than 1, there is a concentration of, in this case, healthcare workers that is greater than the state concentration. So this is looking at the 9 counties versus the state. If it's less than 1, then it means that there is less of a concentration than the state, and greater than 1, there is more of a concentration than we see statewide. So let's get into some of these occupations, and one more slide just about methodology. I considered 60 different occupations in healthcare and focused on the largest dozen of those. In other words, the largest by numbers in the 9 counties. And I was able to do this for what we call workforce development areas for Benton Franklin counties, Lewiston, Clarkston, so that, and that should be Clarkston, excuse me. So it contains a bit of Idaho, Walla Walla, and Yakima. So omitted are Columbia, Garfield, and Kittitas counties. And again, my apologies, but that's just the way the data come out. Again, the reference region here is Washington. The time period is 2023, so fairly recent. We'll get another report out in couple of months. And if you're interested, the source for this is the Occupational and Employment Survey from Washington ESD. Next slide, please. So here we go. I have three different groupings, what I'm calling mid-levels, and I didn't have a better name for that, but if you'll look at the x-axis, we're looking at physical therapists, dental hygienists, substance abuse and mental health counselors, and pharmacists. And lo and behold, I mean, I had no notion going into this what the location quotients would be, the size of them would be, but you'll see that the values for these four occupations for Greater Health Now are all greater than one or higher. So that means that we in these 9 counties have a greater concentration than throughout the state. That does not imply by any means that the supply level is adequate, just says relative to Washington, it's larger. So it's led by PTs, and just at sort of parity with the state are pharmacists. Next slide, please. So I then looked at 5, not 4 occupations that are assistants and technicians. And these are left to right, home health care and personal care aides, CNAs, pharmacy techs, dental assistants, and medical assistants. And look what we found is that the relative concentration of numbers in these 5 occupations throughout the 9 counties is actually higher than the state as a whole. So that surprised me anyway. And we'll wrap up then with the last group of the top dozen. And this is looking at nurse practitioners, nurses, and physicians. And here the story is a bit different. While nurse practitioners have a frequency, a concentration more or less equal to the state, the same is not true of nurses and especially physicians. So we can say that those latter 2 occupations are underrepresented relative to the rest of the state. I have a bit of a caveat here. The data from Walla Walla weren't as rich as I had hoped. And after I contacted the labor economist who tracks Walla Walla, she mentioned that due to data suppression issues, small sample size, that some of these entities just got omitted. So my guess would be that the numbers are a bit higher for all 3 of these, if we can know the actual numbers for Walla Walla. But my bet is that the location quotients are still going to be less than 1 for Greater Health Now for both nurses and physicians. So I'll just wrap up with this last slide. Oh, one more slide before I wrap up. I just wanted to show where we might get a couple slides here, excuse me, where we might get our future workforce. And I've got 3 looks at our population by educational attainment. And this one is looking at some college, but no degree. And you can see that most of the counties in the 9-county area exceed the Washington average here. And one can interpret that 2 different ways, either high success in certificate giving, or perhaps that there's a high dropout rate from community colleges or higher ed in general. But you can see the Washington average is 22%. Next slide, please. I got to finish up here to be mindful of time. These are people who have an AA degree. It's a lower number, ranges 18 to 14%. We very often have higher shares than the state of Washington, which is 10% of the adult population, by the way. And I just made a comment here at the end that I think this augurs pretty well for the infrastructure to train mid-levels and LPNs. with what I call a strength of the community college system in the 9 counties. And finally, next slide, please, is looking at the share of adults with a bachelor's degree or higher. And here, the 9 counties is way below what we see statewide. We have a pretty high average statewide of 38% with a bachelor's degree or higher, and there's only 1 county, not surprisingly, College Town, Whitman, with a much higher than the state average, but every other one is lower. And so I just posed the question that this might be a challenge if we're going to do training our own, because to get to some of these degrees, certainly nurse practitioners, physician's assistants, and of course doctors, we're going to need at least a bachelor's degree from our population. Okay, so I will wrap up with this slide about this supply side. Basically, a big red flag here is that the labor force in general has shrunk, and I don't see it growing fast anytime soon. I think 2024 numbers will show us higher than 2019, but as of 2023, we're still lower. Educational profile is a bit different than Washington's, which could create a problem for some of the higher occupations by training, but promise for the lower occupations by training. I'll leave it at that. So that is it from our perch here at the Institute. And I want to see, I probably ran over a little bit, so I will forgo questions until the end. If you could hold them, maybe I can answer them in the chat as we go into our next speaker, who is Benjamin Stubbs. So Ben, the floor is yours.
Great, thank you. Nice presentation there, and I'll look to follow it up with some more information shortly as soon as I can get my slides up. Okay, hopefully you're seeing my first slide there.
We are.
Great. Thanks for having me here. By way of introduction, my name is Ben Stubbs. I work at the University of Washington Center for Health Workforce Studies. And one of the main programs I work on is something called the Health Workforce Sentinel Network. So I'm here to talk to you a little bit about that. And Patrick, thanks for that great starting presentation. You covered some great information about supply and demand around health workforce. And the demand that Patrick was talking about is around population demand for healthcare services. So, you know, knowing about the population in a given area is important for that marker of demand. The Health Workforce Sentinel Network looks at a little bit. It also looks at demand, but in a little different way. The demand I'll be talking about is focused more on healthcare employers and their demand for employees. So if I use the word demand, that's the context that I'm using it in here around the Sentinel Network. So just want to start with that statement to sort of orient you to what we'll be talking about. Another thing that's a unique aspect of the Sentinel Network is that it's designed to give information about the how and why behind health workforce employer demand. And so a lot of surveys looking at workforce demand from the employer side will, go to a facility and ask, how many vacancies do you have? What percentage of your workforce, what's your total workforce? And then you can calculate what percentage of vacancies are in that facility. So that's a very quantitative look at demand. The Sentinel Network is really looking at the how and why and trying to understand, the why behind those numbers. So just want to start out with those caveats, I guess, and orient everyone to what we'll be talking about here. So with that in mind, I'll jump in. And give a little brief background on the Sentinel Network. So the Sentinel Network was developed starting in 2016 as a partnership between the Washington Workforce Training and Education Coordinating Board and the University of Washington Center for Health Workforce Studies. And there's ongoing funding provided by the Washington State Legislature. So it's a statewide initiative, but as you'll see, we can get great information about more local areas of the state. And Renee will be following me and talk a little bit more about this partnership between the Workforce Board and the Center for Health Workforce Studies. So the purpose of the Sentinel Network is to, as I said, to understand signals or the how and why behind employer demand for healthcare workers. It's been active since 2016. So another feature is that we can track and understand trends over time. And we also are interested in making this information available to everyone in the state. So if you're not familiar with the Sentinel Network, hopefully this is a good introduction and will serve as an introduction to the Sentinel Network, and hopefully you can use it as a valuable resource going forward if you aren't already. So what does the Sentinel Network do? Like I said, the goal is to understand employer needs for healthcare workforce. And we ask a series of questions every 6 months. So every 6 months, we make this online survey available to healthcare employers across the state. And we ask questions about the topics that you see underlined in orange here on this slide. So a variety of topics around vacancies, meaning how many openings do you have at your facility? Turnover, are you losing employees and what are the reasons why? Any new occupations you're hiring, which could give an indication of sort of new directions that organizations are going, and relatedly new roles for existing employees. And then also a little bit of information about orientation and onboarding priorities and training priorities at the organizations. And then we also ask if the organization primarily serves urban, rural, or a mix of urban and rural. So we can get a self-reported indication of kind of urban versus rural services in the state. And then since the pandemic, really, we started adding a set of what we call questions of interest or overarching questions. So each 6 months, we work with our partners to understand what are some of the really important questions around workforce that you're interested in knowing. And then we'll put those into the survey so that we can get kind of the pulse of the workforce situation in the state. So as I said, the survey is statewide in focus. We try to capture a wide range of healthcare providers in the state. So ranges from hospitals to long-term care facilities, to dental clinics, to K through 12 schools, any organization that is hiring healthcare workers and providing healthcare in the state. We also ask about a wide range of occupations. And as I mentioned, we try to cover all areas of the state, and we report the information by accountable community of health. We can't quite get down to the county level due to numbers issues, but we can look at accountable community of health as a region. And then, as I said, the goal is to make all of this information available. So there's a publicly facing website, and the web address is there at the bottom, wa.sentinelnetwork.org. And I encourage you to explore if you haven't already. But one of the features of that website is that we create dashboards that present all of the information that we gather every 6 months. And we present the information by facility type, by geographic region, and also by the self-reported rural urban indicator. So there are several different ways to look at the data. And another data product that we provide is what we call findings briefs. These are 3 to 4 page summaries, high-level summaries of the findings from each 6-month data collection period. And as you can see here, there's a list of the different findings briefs that we've created for the last 2 data collection rounds. And they're primarily broken up by what we call facility type or type of organization, so assisted living facilities, behavioral health clinics. But we also try to look at nursing occupations or rural healthcare providers. So there's some interesting information there that synthesizes the findings a little bit more than the dashboards do. And so finally wanted to talk about, well, not finally, but as far as way of introduction, maybe a way to think about the Sentinel Network findings is a little bit different than some of the maybe quantitative information around vacancies and other employer demand indicators. And so what we're really looking for is signals or indicators that may back up the information that you're finding in other data sources. So the Sentinel Network is really meant to complement these other data sources and provide deeper, richer information to help explain the numbers. So I'd encourage you, as in my next slides, I'll go through some of the recent findings from the Greater Health Now region to think about the data in these ways. So what is the signal that we're seeing? What is it? And does it agree with what you've heard elsewhere or what the numbers that you've seen indicate? And then what does that signal tell you about maybe possible solutions? And then when you're thinking of solutions, there are several different buckets, I guess you could say, that you can put those solutions into. They're like education and training solutions. So increasing the number of seats at an educational facility and producing more workers is one solution. But another solution is that maybe you focus on incumbent or training solutions for current workers instead of the long process of educating new workers. Maybe a solution can focus on the current workers and training them up or giving them different skills. There could be policy or regulation solutions, like if there's a backup in licensing, are there things that you can do working with the state to solve that problem? A general topic maybe, or a general term is the healthcare marketplace. You know, if there are discrepancies in wages, what are solutions that we can think of on a state level to help you know, increase wages or at least balance wages between different employer types within the same occupation, and maybe other solutions that you can think of. So keep those in your mind as we look through some findings from the most recent data collection rounds focused on the 9-county region of Greater Health Now. Diving into those findings, we collected information in the spring of 2023, the spring of 2024 and the fall of 2023. Approximately every 6 months we collect the information. And this shows that we received responses from 138 facility or organizations from the Greater Health Now during that time period, and shows the other regions, the response we got from other regions. And yeah, Nicole, it's great news. Greater Health Now has been a great partner of the Sentinel Network and has been a strong, organizations from Greater Health Now have been strong participants. So that's great news. And I think a lot of it is really thanks to the partnership with Greater Health Now, ACH as an organization, and your great advocacy within the region. So this is kind of a lot of information, but basically the what this is showing you is the facility organization types that from Greater Health Now, ACH, that responded during that approximately 1 year period from fall 2023 to spring 2024. So at the top, behavioral health facilities with about 31 responses during those 2 time periods, long-term care, FQHCs, public health, et cetera. So you can see the kind of range or relative number of responses from each of those. And as you can see, the number of responses can be a little bit low, but that's part of what we're looking for is signals. And so even though the number of responses can be low for certain facility types, we can still get great information about the challenges that they're facing. And then to the right, you can see the rural-urban breakdown of self-reported service provision for each of those facility types. Overall, just under half of the organizations reported that they serve primarily rural clients or patients. So part of the information we can gather from these organizations is what are the occupations that you are having trouble hiring? And one way we can say that is what are the occupations with exceptionally long vacancies? And we see here the list of occupations that were reported in fall through spring as being especially difficult to hire for those organizations that responded. Can see top of the list is registered nurses, mental health counselors, physicians, surgeons. And I'd like you to recall one of the slides that Patrick showed indicating that the supply, especially for registered nurses and physicians in the Greater Health Now region, relative to the rest of the state is somewhat lower. And as he mentioned, that doesn't necessarily mean that there are enough or too little, but this is a, triangulation. This is another data point indicating that employers at least are indicating that these are occupations that they're having trouble hiring. Interestingly, you'll see other occupations that Patrick mentioned, such as dental hygienists, substance use disorder professionals. In Patrick's slides, those were some of the occupations that had a little bit higher supply in Greater Health Now compared to Washington. But we can see that at least from this information, employers are saying they're still having trouble finding enough, or at least being able to fill the positions that they want to for those occupations. So as I mentioned, the goal of the Sentinel Network is to understand the how and why. And so I'm going to start presenting some of the quotes from respondents to the Sentinel Network that help us understand why is it that they're having trouble hiring some of these occupations. Oh, sorry. First, before I do that, forgot this slide is here. We can break down the occupations by facility type. So I'll show the top 4 responding facilities from this time period. Behavioral health facilities indicate that their top occupations that they're looking for are substance use disorder professionals, mental health counselors, marriage and family therapists, and the rest that you see there. So maybe not too much of a surprise. Long-term care facilities, registered nurses, nursing assistants, social workers. Again, probably not a surprise, but hopefully at least confirms what you're seeing or hearing from other sources of information. Public health organizations looking for registered nurses, physicians, substance use disorder professionals. And FQHCs or community clinics in the region, Greater Health Now region, also looking for registered nurses, physicians, and then add to that social workers with a child, family, and school specification. So now we can get into some of the reasons. What are employers saying are some of the reasons why this is happening? When we look at registered nurses, there's reports that organizations of different types are competing with each other for nurses. And what that can lead to is that the nurses have a lot of say in what kind of salary they're asking for, what kind of working conditions. And so there are some quotes here that indicate that situation. The first quote says, you know, we continue to use agency nurses since COVID began in 2020. We feel like there aren't enough registered nurses and LPNs in our region, and our hospitals, nursing homes, and clinics just steal from each other, in the words of this employer, and staff rotate from one location to another. Another issue indicated by the second quote, hospital nurses are used to working 3 days a week, and they do not want to switch to work to 5 days a week. So different organizations have different staffing models, and if a nurse is used to or wants a certain schedule, that may make it difficult to find one that matches the employer's requirements. And then final quote, all facilities are competing for the same applicants. This highest dollar seems to win. And the employees will do fill-in work at a number of facilities and not commit to full-time at any one facility. Another theme that came up is that employers in rural areas report additional challenges. These two quotes indicate that. The first quote says that, you know, I really like the idea of an apprenticeship program, hosting students, and potentially some additional programs that offer tuition assistance for RNs to take jobs specifically in rural health. And I'm also interested in ways to recruit and host people from other countries. So they're thinking of creatively and of different ways to attract workers. And the final quote, we lost several full-time staff during COVID and who chose not to return to the agency. Our facilities are often in remote locations where housing can be a concern as well. So this indicates that there are some factors a little bit out of the control of the employer, such as housing. Another topic that we've heard about is transportation and childcare. Those can really affect ability to hire, especially in rural locations. So looking at mental health counselors, we see a lot of the similar issues as was reported for registered nurses. And I should mention those issues around wage competition and difficulty for rural areas kind of reach across almost all occupations that we'll look at. But for mental health counselors, there are a few different issues that employers are mentioning around licensing difficulties and specific skills that they need. So for example, this indicates that the wage issue is an issue with mental health counselors as well as other occupations. And then these last three quotes, I won't read through them, but indicate that the first one indicating that the licensure applications to the state are taking a long time, and that's been a difficulty for them in hiring mental health counselors. Second quote indicating that, again, the licensing at the state level can take a long time, but also they have high needs clients, and that can be something that may not be attractive to some of the people that they're trying to hire. So, and then finally, the last quote, seeking counselors with youth and bilingual experiences. So very specific skills that they're looking for. Looking at medical assistance, again, the wages and rural issues appear, but interestingly, some creative solutions around medical assistance are being reported by employers around internal training programs, mentorship programs, apprenticeships, and general kind of grow your own employees. And so I won't read through these, but these are some quotes that you can look at later when these slides are made available that indicate that there are several approaches that people are taking to sort of grow their own medical assistance. And then the last I wanted to talk about is dental hygienists. This is something that we're hearing statewide and also in Greater Health Now is a great need for dental hygienists. And so some quotes here. There's a general shortage of dental hygienists in Washington. Many retired or left during COVID, and the class sizes are small. And people only work for 6 to 7 years. The next quote gives some more information about that, saying it's a demanding job physically, and that can lead to burnout. And so suggesting some some solutions around that. And then a final quote, we only have 2 part-time dental hygienists 1 day per week, which really limits the schedule that they're able to see patients in this particular clinic or office. So hopefully that gives you an idea of some of the information that's available in the Sentinel network, how it's a little bit different than other sources of employer demand information, but how it can give you some really rich background and possible ideas for possible solutions. And so we really see that as the value of the Sentinel network. If you haven't already, please register to be a Sentinel. We just closed our most recent data collection round, but in approximately March or April of, or I'm sorry, we're already past March or April. In approximately October, we'll open our next data collection round. And so if you register today, we'll contact you when that comes around, and you can provide your information and become part of this great resource in the state. We're also happy to provide tutorials about how to use the data dashboard. If you have specific questions you'd like us to investigate, we're happy to consider those. And we're always open to feedback on how we can serve you better and how we can improve. So please don't hesitate to reach out and let us know what your needs are and what your finding as you explore the dashboard. We're always interested to know what your take on the data is, et cetera. So please don't hesitate to reach out. I didn't get too much into how these data are used on a statewide level. And so hopefully I'm kind of setting the stage for our next presenter, who will talk a lot more about how our policy, in general, policy decisions discussed, at least in the state, and some concrete examples of how Sentinel Network and other data sources can inform that discussion. So again, we'll hold questions until the end, or if you have questions in the chat, I'll try to answer them during Renee's presentation, but I'll stop there.
Thank you, Ben. That was, I've listened to Dan talk about the Sentinel Network for years, and I learned a lot from what you just showed us. So I hope there will be questions for Ben and now Renee. And we will have time to take those, I think, as we go through the hour. So Renee, the floor is yours.
Thank you very much. So I'm Renee Fullerton. I'm a policy associate with the Workforce Board. We don't usually use the whole name. It is a mouthful for sure, as several folks have mentioned today. And my main role is serving as staff to the Health Workforce Council. And I'm so excited to be with you guys here today. It's wonderful to talk to those who are actually in community doing the difficult work that needs to happen to get access to care for all of our patients. So high demand for healthcare workers is not something I'm ever going to describe as a new trend in Washington. If you're a report collector, kind of like myself, this use of the word crisis to describe the healthcare workforce here within the state has been around for a long time. This report I linked to here is from 2002, which was the original healthcare personnel shortage task force report that was created 20 years ago, when the original effort to bring together representatives from government, labor, professional groups, the educational institutions, and the facility employers. The council has been meeting continuously since 2002, although it also sort of has its ebbs and flows depending on whether there is funding for staff specific to the effort. And once you get this slide deck, that is a link there on that bottom bullet point, so you can go and find out about our meetings. We meet 4 times a year. We're very excited to be coming in person to Yakima at the end of June, and you all are welcome to join us there. We would love to have you. So what is the net result? What does the council do? The council is a policy advisory body. So basically what that all results in from those meetings and from the work outside those meetings is an annual report to policymakers that goes forward every December with recommendations and information about the health workforce supply and employer demand within the state. Over this most recent biennium, so 2022 and 2023 and 2024, we have been focusing on addressing the health workforce educational debt and sort of the idea of broadening the conversation beyond loan repayment, which has been sort of the first line solution for healthcare workforce debt issues over the years. And then also trying to raise attention, although we cannot fix it, to how access to community resources such as childcare, affordable housing, and transportation is really dramatically impacting people's ability to find and maintain employment, and also to even enter the education training pathways. Given the young population that Patrick discussed within this particular area, childcare seems like it would be a particularly challenging focus because all of those young folks represented in the bar charts have parents, and if those children don't have somewhere to go, those parents' employment opportunities are going to be a lot more limited, particularly if you're talking about staffing 24-hour care facilities, because while it is difficult to access care during the day, it can be nigh unto impossible to find after hours or overnight childcare needed by those who are staffing long-term care facilities, hospitals, and other residential sites. So you just heard a whole lot from Ben about what the Sentinel Network is, what it collects. This is a graphic that the team at University of Washington has used for years that sort of describes the flow, and it's lots of tiny type. And the main point I wanted to take away from this piece is this last sort of teal box. What are we doing with all of this information that is being gathered, a great effort by the university team with all of the many hours combined, from the employers who are responding to the system over the years? How do we take the information that comes to us, view it, discuss it, and make something happen that is actually addressing the real challenges that employers are expressing to us? So unfortunately, as a policy shop of one, I was not able to pull together Greater Health Now specific information for what I'm going to talk through in the next couple slides. So all the information from here on out is statewide, but I think you're going to find it's going to gel very similarly with what Patrick and Ben were able to talk about with their specific needs within this area. So what's here on the screen is what UW creates for all the policy briefs, which is a matrix. It shows sort of a ranking like Ben had pulled out. What are the highest reported professions that employers are having the most difficulty recruiting over time? And this is for all behavioral health facilities reporting within a particular time frame. This one is capturing spring 2023. And this one, as you saw with the data that Ben had, this matches very closely with need for mental health counselors, substance use disorder professionals, even registered nurses, which people don't necessarily always think of as a behavioral health profession, are showing up on this chart as being really difficult to hire. So then the question becomes, how does this compare to our supply? The employers are telling us that they are having extreme challenges hiring these particular individuals. What is our educational system graduating, and what is our total licensure count in the state? So we take the employer data that comes from the Sentinel Network, and in our annual reports, we try to triangulate that with what's going on within our training system and the overall supply that's represented by total licensure within the state. This chart, what this is showing you is, it's very simple, it's high level. This is the change in these 5 professions that are named in the bottom in total number of licensees in Washington state since 2014, % change. So you see the grouping up here that has sort of the strong upward trend. These are the 3 master's level behavioral health professions. So licensed mental health counselors, licensed independent clinical social workers, and licensed marriage and family therapists. And they're showing very similar outcomes in here, where we are having, pretty strong trend. We hit 2020, and then really things take off with sort of an inflection point change in how many licensees that we're having. And then the interesting contrast here is with the substance use disorder profession, which employers are telling us is strong demand, very difficult to hire, but we're not seeing educational output or total number of licensees increasing as you would hope to ramp up to meet that particular demand. So the purplish line down here, this is showing our total number of fully licensed substance use disorder professionals, which was a slight total number of licensee decline even from 22 to 23. And then what's even more concerning for our long-term trend is this yellow line, which represents our trainees. SUD professional trainees, it's an interesting profession because the people who are actually in training also have to have a license, which is dissimilar from other health professions, but it gives us a good view of what's coming. And so this represents those who are in the process of training right now. And you can see we're actually below our 2014 percentage. We've declined. And so that's a concerning trend as we think about where we're going, given the high demand for this particular profession. Now, the challenge of this is one high-level piece of information statewide, and you can think through a lot of different reasons for why this might be showing you what it is. But I don't have specificity of data right now to be able to tell you, for example, how many of those master's level folks are working in private practice and so are not available to employers in, say, the community health centers or the community behavioral health system to provide services. Another question showing this big trend change, how much of this trend is caused by providers who don't live in Washington, but have become licensed to provide telehealth services? So we don't know how much of this particular supply represents workers who are available in Washington to serve patients face-to-face, which is the typical care model in community behavioral health, versus folks who are out of state and are providing services through some of the national platforms that are available, where it becomes common for a clinician to be licensed in a large number of states. A bill passed in 2023 that is going to require a collection of some additional points of information about our health workforce that we have not had, specifically practice location at the time when they renewed their licenses, and race ethnicity, because in addition to not knowing where people practice, we also have not had a sense whether we've made any progress in creating a health workforce that is reflective of the population it's serving here within Washington. Click over to my next slide. So now we've gotten sort of this picture. We have sort of the general signaling that those professions are a challenge in the behavioral health side. We have sort of a sense from our licensure trends that, okay, training, we're having more and more and more of these master level folks, substance use disorder professionals, production's lagging too. So that's an interesting different set of problems that are coming there. Then we can go to some of those qualitative pieces that Ben was talking about, to look at some of the why behind these and what are potential things we can do to address the trends. So I pulled this quote, which is from spring 2023, which discusses a particular challenge that many employers, both in Greater Health Now and across the state in the behavioral health side, point to, which is the challenge of providing training to new behavioral health professionals uncompensated. There's not funding available traditionally for this key role that employers play in educating the behavioral health workforce within the state. So I picked this example because it points to what you can do when you have a piece of information like this. This supervision challenge has been a consistent signal across the Sentinel Network data since 2016. We've known about this for quite a long period of time. And so Greater Health Now has always been very active in taking Sentinel Network data and using it to consider how they invest their resources. So Greater Health Now started sort of this policy cycle I'm going to talk about by incentivizing participation of the area's facilities in the Sentinel Network. You guys are great at getting healthcare employers to go back and put in this information that allows us to show longitudinal change over time. And then Greater Health Now spent the time to go through all the data itself and highlight, okay, what are things that we could change as an accountable community of health? What is amenable to things that are within our power? And so they honed in on this supervision piece and entered a policy cycle where Greater Health Now decided to use some of the funds they had available to help pay employers to incentivize supervision at behavioral health sites, sort of entirely on their own, is my understanding. This model was successful. It was popular with employers. It was able to show outcomes. And I believe in 2021, the legislature passed a bill that appropriated funding to expand that to a multi-ACH pilot. So there was $1 million that was given by the legislature to say, okay, Greater Health Now has shown progress in addressing this particular challenge. Let's try that and see if we can replicate that. So that $1 million went out to Greater Health Now to continue to Thriving Together up in North Central and to the Southwest ACH to further this. So then in 2023, that project, unfortunately, it was not ongoing funding. It was, we like to fund in 2-year cycles. It's a bit of a challenge. That work wrapped up, and the ACH has reported their outcomes from that pilot to Healthcare Authority. Healthcare Authority has responsibility to assemble all that together. What did we learn from this? What were the outcomes of this? And report that to the legislature. Now, reports, as I say, I collect reports. I love reports. Reports are part of the policy conversation. And once you can get a report out there, it gives you kind of a leg to stand on insofar as when you want to talk about these particular issues. So now that the report from Healthcare Authority is out in the policy conversation, we're able to bring it to the groups that are discussing all the behavioral health workforce challenges we have and say, look, there was this recognized need to address a supervision gap. And ACH identified it. They did something about it. The legislature decided to expand that. We've shown good outcomes from that. This is something we need to do more of. And so now there are policy conversations underway right now about an ask for 2025 in a couple different ways. There is a group, the Council for Behavioral Health, is looking at implementation of a Medicaid teaching clinic rate, sort of getting to this idea of how do we sustainably fund this key training point or training work that is being done by the behavioral health employers here within the state. And then the ACH groups are also out sort of presenting the results from this. And I'm excited to be hosting them at our Yakima meeting to discuss the lessons learned from Greater Health Now and Thriving Together and Southwest about how this impacted the employers in their particular areas. And sort of key takeaways seem to be the more flexible we can be with these types of funds, the more creative employers can be and the better solutions we get from these as well. Within behavioral health and sector in particular, funds tend to be very locked down to reimbursement for specific services. And the results of some of this pilot is showing that sometimes the more freedom we can give people, the better outcomes we'll be able to get. So this conversation is very much underway right now over the summer as people are developing their policy asks for 2025. And I suspect you will see more. And I'll be sharing out with Nicole and others greater ACH sort of what I'm seeing with conversations and places where folks, if they're interested, can lean in and help, inform their legislators about the impact of this work and how to move forward to sort of address what this has been this continual problem here within the state. So that was one particular example of Greater Health Now leaning in with the Sentinel Network and using funding as a way to help resolve a challenge. But funding is one solution for things, but we really have a whole series of policy levers at the state level, given our responsibility for occupational licensing, for regulation of the healthcare facilities, or how we fund our educational system, how we fund our provider incentive programs. And Louise from Student Achievement Council is going to talk next about some of the resources that are available for that. And then also sort of these key things around planning data. Do we know what we need to know about our current health workforce to make the changes that we want to make happen? And then the piece that always gets me, research and then evaluation. How do we know what's working is actually working if we don't go back and evaluate it? And that unfortunately is a continual challenge, I think, within the government space. It's going back to check to see if we had the anticipated impacts of what we did over a longer time span than, say, a biennial funding cycle. So as you're looking at Sentinel Network data or as you're entering policy conversations, be thinking about all the different levers that can be pulled to help get us to where we want to go in developing the health workforce that we need here within the state. Kind of our overall takeaway I'd love to leave you with is just the idea that we're really trying to move what is a massive ecosystem. As Patrick said, it's the second, third largest employer within the Greater Health Now region. It's a major source of income for the people within this area who are working in the healthcare sector. And also when you add in, say, the educational sector for folks who are training our future healthcare employers, the government side of things, healthcare is implicated in a lot of sectors outside beyond what is just showing up within sort of the health and social services line as well. but that makes it also really complicated to try to move in a coordinated fashion. There's no one group who's going to be able to fix all these different challenges. It takes everyone from the local all the way up to the federal level leaning in to get us where we need to go. And so that's why I'm so proud of the efforts that Greater Health Now has done to really proactively get involved in workforce development. We need collaboration in all of this, and especially rural voices. Oftentimes, I'm in a lot of meetings where there are many folks from the West Side in attendance, and maybe if I'm lucky, you know, there's some East Siders, or there's Spokane, or there's Yakima. But you know, I'm always curious, you know, where's Sunnyside in all this? Where's Grandview? Where's Prosser? Where's Dayton? You know, where are the folks who are out there in our further out there communities whose voices may not be heard? And it's hard. I get it, because you know, if you're in rural, you're wearing many different hats. You're having to do all the different things at the same time. But whenever you do get a chance to come and talk to those of us who are in supporting roles, we do so appreciate it. Or even if it's not coming to meetings, but if you can do the Sentinel Network, every bit helps, because you know, as a holder of the reports, as a writer of the long, boring documents that do give us a policy leg to stand on, if we don't understand your challenges and what's going on in your communities, we can't accurately represent them to policymakers, nor suggest and promote ways to help fix them. So thank you all for everything that you do. And you have very hard jobs out there actually doing the hard thing, versus me sitting here on the government side of things trying to help you do the hard thing. So I appreciate all of your work and joining us today.
Oh, thank you, Renee. That was wonderful. Now I not only can spit out where you work, but I think I can actually repeat what some of the stuff you do. So that's a good takeaway. We will have questions here shortly, but we need to hear from our last presenter, and that's Luis Cepeda Chavez from WASAC. So Luis, are you ready to give us the perspective from the Washington State Student Achievement Council?
Yeah, let me share my screen here.
Okay, the floor is yours.
All right, how does that look? Are you all able to see that?
We can see it. Thank you.
All right, perfect. All right, yeah, well, good morning, everyone. My name is Luis Cepeda. I use he, him pronouns. I'm the program manager for the Health Corps programs here at the Washington Student Achievement Council. I'm also joined by our awesome director, Inez Olive, in the audience here for support. But let's get into it. Okay. All right. So yeah, just a quick overview of our programs. It was established in 1989 to address healthcare workforce shortages. That's still our main goal today. There was a recent rebrand back in 2016, I believe, where it was previously known as the State Health Professional Loan Repayment Program. It is now known as the State Health Program, a lot shorter, simpler. And our similar federal program is now the Federal Health Program rather than the FSLRP. The Health Corps, as we know it today, was established by the 2019 legislature, with the establishment also of the behavioral health program, which is specific to behavioral health licenses. In general, our programs currently include student loan repayment programs for healthcare professionals already in the field. And in this work, we work closely with the Department of Health to identify licenses and professions that are in shortage, and also rural and underserved areas that are in shortage and need of support in the workforce. We also work closely with the planning committee, which consists of several stakeholders across the state, in advising us in prioritizing licenses, and and help us with awarding with our cohorts. Just some additional information: when our program was reinstated following the recession, our initial funding was for $5,210,000 across our programs, across our state programs. And yeah, this is an overview on our programs. Our main item in our portfolio is student loan repayment program. So we have three kind of flavors to that. We have our federal award, which is a 2-year contract. That is up to 70,000 in student loan relief. If you qualify for that, some of that is depending on the services provided, the license, and also the site that you work at. That is a full-time only contract with us, so you would have to report 40 hours a week. And we have two state contracts, which is the state health program, which I mentioned earlier, and the newer behavioral health program, which is specific to behavioral health licenses. These are 3-year contracts, up to 5 years if you work less than full time, up to 75,000 in student loan relief over the length of the contract with us. We have a little bit more flexibility with that since it's fully state funded. And so you could work 40 hours per week. That's a three-year commitment. If you work less than that, at least more than 24 hours a week, you would still be in good standing and you could potentially see a 5-year contract, although most folks finish it sooner than that. And yeah, here we have some of the licenses available. I think I'll drop a link in the chat later to have a more breakdown since this might be a lot to look at. We'll also go over the timeline near the end of the presentation, but we just wrapped up our recent cycle this year at the beginning of March, and we are currently still reviewing applications, and we're hoping to select our cohort for this year sometime next month. So yeah, pretty exciting. Let me go to the next slide. Yeah, so some information on our funding sources. Our federal program is funded by a federal grant match. And so we contribute some funds from the state, and we also have a matching grant from the federal government. We also have our 2 state programs, the SHP and BHP, are funded a bit separately. So you'll notice that something I want to highlight here is the influx of funds that we received recently for our behavioral health program, which shows that the legislature has seen an increased interest in having this funded and ensuring that we are able to support the workforce in that sector. We've also just standard up a new nurse educator program, which is also a student loan repayment program. And our funding was 6 million for the biennium. We've wrapped up our first year with the nurse educators this July. So hopeful to get some more information on that, but it's still fairly new. Wanted to share some information on our applications that we've had to date. 2016 is really when we started to modernize our approach to selection. That although there was where you had to submit application information by mail, and starting in 2018 is when program staff were able to provide more hands-on support in ensuring that there was a smoother introduction of applicants to our programs, which was really helpful. Unfortunately, there was a dip in 2019 due to some internal revisions. 2020, we bounced back to having a strong performance there, but yeah, our applications traditionally go from January to March. So the following year, we see that dip because of the pandemic. But we've been climbing up again, and we're still currently reviewing for our current cycle. But I will say that I think we've gotten a new record this year. But once we close out this cycle, we'll have more information to share then. But yeah, something to note here is that our application, it's one application and it applies to our 3 programs. And depending on the responses from applicants, our system filters out their eligibility for the 3 awards. And something else to note is that if someone applies and is awarded, they don't have to reapply in the future. So these numbers include new applicants and people who we just weren't able to fund in years prior. Here's the breakdown of our folks who applied in the 2023 cycle. Here we see the folks that were eligible for the program, for each program, and then how many were awarded from those. Something else I wanted to highlight here, the number of folks that we were able to award because of the increased funding for our behavioral health program, which you'll see the greatest numbers of folks awarded there. yeah, you might see a smaller number with our federal programs, but if they're eligible for our federal programs, they're likely eligible for our state awards. And so you'll see some of them being funded in our 2 state sub-programs there. And the list here is also shows the folks that are eligible for our programs. Some of them, if you see like the little dash signs, it's because they're not eligible or prioritized for those programs. We like to prioritize behavioral health within the behavioral health award just because of the funding that we have allowed. And some because of the federal funding is a little bit stricter. Some licenses aren't eligible for that award. And now I'll go over our nurse educator program. This is also an award up to $75,000 in student loan relief over a 3 to 5 year contract. It's 3 years if you're working full time as a nurse educator. You must be have a valid nurse license or hold an advanced degree beyond a bachelor's degree and teach at an approved Washington nursing school. We've had quite a few applicants in the first year of implementation, also this year as well. It's looking like we're going to be able to fund a lot of folks this year, which is awesome. Yeah, like I mentioned, our service obligation for this program, 3 to 5 years, depending on if they're full-time or part-time. And the requirement is that they teach at least 1 class per academic term. So that's 1 class for 3 quarters on the quarter system, and 1 class for 2 semesters on the semester system. And this is the breakdown of the awardee cohort for last year's cycle. We had 58 applicants, and of those 58 applicants, 44 were awarded, 10 were part-time, 34 were full-time, and this is the breakdown of the institutions they teach at. We say that 16% of awardees were from 4-year colleges, 30% were from minority serving institutions, and 54% were from community and technical colleges. And now we'll just go over briefly the application process and timeline, since maybe for some folks this is brand new to them. I will mention our approved list is always changing. We always encourage folks to apply to be considered within our program. We review applications year round. We try to encourage folks to apply before the application period of January through March, just because of capacity. But if you review our reference guide and you feel or if you have questions, feel free to reach out. We also work with folks. But yeah, our next cycle will open in January 2025. Usually the first week, maybe like a Wednesday of the first week. The application will also close early March. And yeah, we are always encouraging folks to apply to become a participating site within our program. Some things I want to note is that if you are eligible for like public service loan forgiveness and you are within that pathway to loan forgiveness, you still are eligible for our program. We just the only condition would be if you have like a service obligation, you would not be eligible in those instances. But PSLF folks are welcome to apply, and in some cases that is a pretty nice way to maybe get closer to full loan forgiveness, if possible. And yeah, and if you are interested in participating in one of our sites, you are able to share with potential hirees that you are a participating site. And yeah, we just would really love to see more applications come in. So this is what our year looks like. Our application closes in early March, and from that point forward, we start working with employers to verify the information that applicants sent us. And then we have a scoring session where we review state priorities and just some of the information that applicants have sent over, and with the goal of awarding in late June with contracts starting July 1st. But yeah, I think I'll hold off on questions so that we can open it up for the full group. But here's our program inbox. I'll also drop that in the chat. But yeah, thank you all for your time.
Thank you, Luis. You brought us back to, so we're right on time. So good job. And let's open it up as broadly as we can for questions for either any one of the four speakers. So, and Nicole, I'll need some help if I can't see everybody's hand go up at once. But let's see if we have questions. No questions so far.
If you have questions, I know there were some in the chat, you answered most of them. Raquel had asked one earlier about pay, wage, and distribution. I don't know if you saw that one.
Yeah.
Okay.
Okay.
But if anybody has any questions, feel free to jump right on. I am full of a bursting of emotions right now. I'm not sure if I want to cry or throw up or smile. This was all just hugely rich and wonderful information. It shows how it all connects. And Renee, you joke about this being boring work, but we absolutely need champions like every single one of you presenting today to move this work forward, because this is a really, really important issue. And it takes, like you said, a lot of moving parts. There's just not one piece that needs to move. It takes all of us to do this work. So I invite you all to ask questions. That was a lot of rich information.
So Nicole, if I can jump in.
Oh, I knew you'd do it, Raquel.
Sure.
Welcome.
Hello, everybody. Raquel here from U.S. Senator Patty Murray's office, and I'm very delighted to hear bits and pieces of this conversation around workforce development and high needs for rural communities. So I've been doing some side fingering here to Renee and some others. So yes, Renee, I'm going to reach out to Nova and let her know I will book myself to be here the 27th to hear specifically, or the 26th to hear specifically from the Workforce Council Board. I have Nova on speed dial. Number two is I want to highly encourage all participants to make a federal application for healthcare workforce development. And Senator Murray's office will be very happy to write letters of support. So there is a process for that. And the third thing I want to tap in here, and I'm hoping everybody else is also doing this, is there is pocketed of federal funding coming specifically to rural development or for rural areas. So I cannot stress enough to you that when I use funny words like highly, wink, that I need you to exert your capacities here as your collective engines. And that is the other piece that you need to know is collectively, that is the pathway forward. So I look forward to hearing options, wink, and solutions, wink. And if you can't tell, I'm a former educator. And when I did those things for my students, they knew that there was something coming up that was very helpful for them to know about. Wink.
So Raquel, thank you so much for that information. And so would people on the line be able to call your office and further explore just what those winks are going to do for us?
Well, yes. So I can tell you right now, I just put my email, my work email back in here. That's the best way to contact me right now because I'm remote located at the moment. My work cell phone is also, I'll put that in here.
Thank you.
For folks. I want also 654, sometimes I got to remember what my number is, 654-6684. Oh, kind of crazy. I've been working on alarm systems for the office lately, so many numbers in my head. So I did participate, and I have participated in a few workforce development conversations. I am aware that there is substantial work taking place. I did see Heritage has some funding going to Heritage for their programs. I'm also aware that Yakima Valley Community College received 3 years ago, or maybe FY22, $3 million to do a pathway program that the state came back in and backfilled the next 2 years to do pilot. I'm also aware that the Washington State Department of Veterans Affairs is also looking at the same problem and trying to come up with solutions for veterans. I've been talking with providers, and they're getting me on the road in June here to go listen to rural remote locations. So again, the work that you're doing presenting your data is critical to the processes here, and very timely. So I cannot thank you enough with some of that correlated information. It would be great to get in the hands of the senator. So I look forward to those presentations popping in my inbox. I also want you to know that we just finished our congressionally directed spending applications and programmatic requests for FY25. I do anticipate, we do anticipate them popping around again in FY26 for in 25 for 26. However, subject to change with leadership in the White House. But there are some applications that came forward around rural health, and they looked at the dynamics here of housing for rural communities so that they could attract the workforce into their areas to provide a baseline support. And there's a great person that, if you're not reading some of his work, his name is Mark Perna. And Mark Perna is talking very emphatically about how business and community and agencies can co-collaborate and move forward the initiatives, and what surveys are saying about the workforce. So there's a lot of work here in this space, and I can't wait for these dialogues. So I'm going to go block off my calendar to stay in Yakima for those days. And so if anybody wants to see, meet, or connect, I will make myself available emphatically for those opportunities.
Great. Thank you, Raquel. For those of you who don't know Raquel, she, as you probably just determined, she's got a lot of energy to, I think, bring to bear in this part of the state of Washington. So thank you for all that advocacy, Raquel. Any questions from anybody on the line? Amber, you have something you'd like to bring up?
Hi, Patrick. So yeah, I would love to just complement this conversation by introducing Danny LaForest. So you all saw her at the very beginning of this presentation, and I just thought it would be a beautiful way to kind of capstone her role and her responsibilities with all of the great conversation that's been taking place. So Danny LaForest has recently joined Greater Health Now as our workforce development liaison. So she's going to be working in close partnership with Dan Ferguson in helping Greater Health Now not only continue the work that we've been doing, but advance it even further into other initiatives, other areas of focus. And so we're really excited to have Danny's expertise as well as her knowledge of workforce development in the work that we're going to be doing as we move forward. So Danny, I don't want to put you on the spot, but is there anything you'd like to add to that as it relates to your role and responsibility?
Thank you, Amber. That was really helpful. And yes, I just I want to say thank you all. This was super informative for me as well. I'm just taking it all in for the getting excited about the work that we might be able to do. And yeah, as Amber indicated, my role. So Dan Ferguson is not going anywhere. He's a tried and true part of our network. He's not here today because he's out of the country, but he will be back. And my work is really to connect the kind of high level conversations that we're having in these spaces and try to connect it to the initiatives and programs that we're doing on the ground, and get some really cool programs going. So I'm very excited about that, and it was very nice to meet you all.
Right. Thank you, Danny. Welcome. How long have you been on staff? Less than a month, right?
Yeah, I'm on week 3.
Week 3. You are brand new. Okay, I'll just start the ball rolling here, and I hope this will prompt some of you to unleash your questions. So this is a question both for Renee and Ben, And what one trend, I know there's more than one, but I'm just asking you one trend identify since the start of the pandemic that has just caught your eye in either the Sentinel Network or anything around workforce policy. So Ben, why don't we go with you, and then Renee, if you have a thought about what has really changed since the start of the pandemic in your world.
Well, one thing that started to emerge, maybe 6 months after the pandemic began, is that a lot of employers were losing employees for various reasons, and then working hard to fill those gaps. And one of the solutions was to use traveler or contract workers. And so it's been interesting to see that ebb and flow of that process, kind of a year, maybe end of 2021, mid 2022, lots of reports of having to fill gaps with contract workers. And I think that trend has declined recently, but did leave some lasting effects where it did, they had to pay those people more in a lot of cases, and also gave a lot of employees a feeling of what it was like to work as a contract worker as opposed, and have maybe a little more freedom of movement or a little more choice as opposed to working full time. And so we're still seeing the long-term effects of that, but that's been an interesting trend to track and see how that goes.
Great. Okay. I've certainly heard about that phenomenon in this part of the state of Washington. Renee, what one item or trend would you point to between 2019 and now?
I'd say the change in the conceptualization of childcare as an individual problem versus being a community and a workforce problem. Like if you go back to that 2002 report, it's very narrow. Like it thinks about healthcare workforce and like we need to graduate more nurses, or we have a nurse faculty shortage, or we need to address these or we need to think about retention, but nothing really specific about it. There wasn't any discussion in there around the community resources that enables people to learn and maintain employment. And so the public health person in me loves that we're thinking about these issues a lot more holistically, but also recognizes that, the health workforce, I can't fix childcare, and then if it's employer tied childcare, what does that replicate from all the challenges we know from employer tied health insurance? We got to think through at a really pivotal time, what are the policies that we want to put in place to make a difference, but don't replicate some of the challenges we've seen with employer tied other benefits. I think is probably a major change. And then just overall discussion about the importance of retention versus graduating more. So Sue Skillman at the UW Center for Health Workforce Studies, she always talks about the bathtub, and sort of it doesn't matter how high you turn up the water flowing in the bathtub if it's draining out, just as fast or faster out the bottom. And so focusing on reducing retention, while it's always been a challenge, feels like it's getting more attention too, given the demographic changes. Particularly, this area is blessed in a lot of ways with having youth, but you look at Jefferson County with more than 40% of its population over age 65 now. We have communities that just do not have the workforce that are going to be needed. All right, sorry. You give me an opening, I'm just going to take it and say all the things.
Okay. So retention as well as childcare, and then Ben is looking at the phenomenon of visiting nurses as being really significant trends in the last 5 years. Anybody want to raise his or her hand, their hand, to ask our experts? This is your time. We've only got about 5 or 10 minutes left before we have to sign off. So, Danny, did I see your hand? Was that a hand raise?
Yes, that was a hand raise. I do have a question, and I if there's not a whole lot more to say on it, Renee, that's okay. But you mentioned the impact of telehealth private practice providers within mental health counselor licensure and how that's maybe impacting and skewing our numbers of licensed mental health counselors compared to the actual boots on the ground in the facilities that we need. Is there anything else on that? Is there any impact that we're seeing because of that skew, or is there anything else that you could say on that topic?
It's hard to know until we have more data available. Starting in January of 25, all the renewing healthcare providers will be asked their practice locations at the time of their renewal. And so it'll take time for that to cycle through. Some people renew annually, some every 2 years. Once we know practice location, that will give us a better hint. Probably the best indicators right now, but they haven't finished the analysis yet, is what's going on at Board of Nursing following implementation of the Nurse Licensure Compact, where they have lovely public data dashboards that you can go look at. And there has been a not insignificant drop in the number of RN licenses that we have in Washington State. And they're looking into it because their first read on it is that those addresses for those nurses who have let their licenses lapse are out of state and probably more likely to be in compact states, meaning that those nurses do not live here and are potentially working in the state on nurse triage lines are a really common place where a nurse is credentialed in a lot of different states in order to provide telephone-based triage services, like when you call your clinician after hours. And so nursing board will probably have the first sort of real concrete sense once they've completed their analysis around within their workforce, how is telehealth contributing to all of these things? And it's kind of unknown too, like within the private equity side of things, where we're seeing purchasing of mental health app delivered counseling, sort of all the other different non-traditional ways of delivering services, how much of the healthcare sector or workforce they are pulling up is still something we're working on, but I think it is a challenge going forward as well. Many people are tired, and sitting at home and doing these things through technology maybe feel like a nice break.
Thank you, Renee. Any hands up that we have time for one last question or two? Now's the time. We won't be meeting again on this topic for quite a while, I don't think. At least 6 months would be my guess. So let's see whether we can pick the brains here of our experts. Anybody? All right, I got to pose one more question. So putting both Ben, Renee, and Luis on the spot, what's your crystal ball for one trend over the next 12 months? Sort of up or down, bad or good, positive, negative. What do you see changing in the next 12 months in the world that you work in? Anybody want to take a stab at that? I know sometimes that's a hard one to ask. I get asked to forecast all the time, and I usually say no. So if you say I can't forecast, that's fine. But do you have any look into around the corner? What might be happening in the next 12 months?
I guess I can go first. I don't work too much with data sets like Renee and Ben, but I can speak on at least within my role and the work that we're developing here in the Student Achievement Council. The next few months and even currently, we've seen a lot of interest in behavioral health workforce. I didn't mention it during my slide, so I'll mention it now. But we're currently standing up a behavioral health conditional scholarship to help folks in the pipeline for behavioral health licenses and people in that work. We're also working in collaboration with some other folks on a behavioral health stipend to also help folks who are in apprenticeships and have, and the stipend, from my understanding, could cover things like housing needs or food, just any kind of basic needs that folks might need while they're in that pipeline to becoming a professional in the behavioral health workforce. So definitely seeing right now a lot of trends in, yeah, getting folks standing up in the behavioral health field.
Okay, great. So larger throughput or larger numbers than we saw on your slide. I think it was 50 or so in behavioral health.
Yeah, these will be small pilots initially, but I think it will lead to bigger projects down the line, more folks awarded and more folks yeah, receiving funding.
Well, that's I think I speak for everybody by saying that's pretty welcome news. All right, Renee, Ben, any last minute final thoughts on what it might look like in 2025?
I want to do a 10-year time frame. I want to do a year. These trends don't turn on a dime. I would be curious, the employers, a sense in the room, because they're the ones who actually know. But from where Ben and I sit, sort of at the survey landscape, it feels like there's a lot more employer provided training that's going on than traditionally has been the case in the past, that employers, because they have to, are taking on more active interest in apprenticeship, are doing more direct training of CNAs, of pharmacy techs, of a range of different credentials that don't require post-secondary involvement or are more minimal on the post-secondary involvement. I would anticipate that will continue to grow because the educational sector is limited in some ways too. Like the nursing seats are pretty full, so there's a limit in how much, even if we drive a bunch more people to apply to the system, there's not necessarily a lot more space for them to go into it. But those in this room know more about what they're actually providing or thinking about doing in the next 12 months with their own provision of training than I do, sitting here with my crystal ball.
That's anecdotally something I see in Eastern Washington here. So thank you. Ben, any final thoughts?
Yeah, just kind of seconding what Renee said. I think a trend that's showing up through the Sentinel network is that I hesitate to use the word crisis also, but a year and a half ago, a lot of employers were really struggling to find workers. And I think we're seeing signals that's maybe stabilizing a little bit. Doesn't mean it's perfect or that it's where everyone wants it to be. But I'm interested in seeing what are the strategies that employers are using to help with that stabilization. So Renee mentioned internal training. We hear some employers are providing increases in wages if they can, other retention strategies that employers are using internally, because as we've said, the education pipeline is very important, but can't solve all of the problems. So be interested to hear from people in this room and elsewhere, what is it that is working and that is helping to sort of stem the tide of workers.
Anybody want to take that question and tell the group what seem to be working at your workplace? Okay. Well, I think the clock is running close to the hour, the second hour. So maybe this is a good place to stop and ask Nicole and others at Greater Health Now, what's next?
Well, as Amber jumped in a little bit ago, we see a significant need for investment in workforce development at our ACH. That's why we brought on Danny. We have on Dan. We're pulling all you together to help us inform the work that we're doing and prioritize some of the projects and programs we have going on. Amber or Danny, I don't know if you have anything to add. I don't know if Amber's still on there. She's finding her mute button.
No, I think our biggest focus right now is just getting me up and running, and we have some things on the horizon but aren't ready quite to share with what some of those are just yet. So we will keep everyone updated as those projects become more concrete and ready to share out.
Okay, great. Well, with that, I'm going to let somebody from Greater Health Now have the last word. This Learning Collaborative is not a one and done. I think there's going to be more of these down the pike. So do you have any sense of when the group will reconvene around this topic or another topic?
Danny, you want to show up that last slide so that we know contact information? But yes, this will continue. Our organization has continued to grow and evolve, especially over the last few months, and all for wonderful things as we are getting ready to launch our hub and some of our programs to focus on those key priority areas, especially as we talk about some of those higher needs populations. And we can see the areas that have higher Medicaid lives and less resources and supports. So Anna Sandid, she had to jump off, but she's a senior director of transformational health. She's what I would consider the cat herder. She oversees all of our operations and our team on the pilots and programs we're running. Danny is going to help collaborate and solidify this learning collaborative so that we have continued information and convening and working together and having opportunity for collaboration. You will be seeing stuff from us again as Ben is ready to pump out the next round of surveys and feedback. We will strive to continue to get feedback from our region. We want to be the best. Woo! 138, we're gonna strive to, we'll go way above and beyond that, Ben, because your feedback is important to us and it does inform the work that we do. We are working on our next months. We're gonna work on making this a more regular thing, not just a few times a year. So how that's shaped for our learning collaboratives, we haven't solidified that yet, but we would like to also uplift our voices of our region and showcase some of these folks doing the work, because that's where we're going to get a lot of the real-time data and information as well to help support the data that you see.
Great.
So
sometime this fall, maybe this group will come back together again.
that would be wonderful.
Okay. Well, let me just say on behalf of Greater Health Now, a big thank you to Ben, Renee, and Luis for your presentations, for putting the time into making those. And now I think we all need to digest what we did in our show and tell and see how that can inform the progress that the ACH is making. So with that, we are adjourned. Thank you for staying the course and tuning in, and hopefully see everybody in the fall.
Thank you to our presenters and our wonderful host, Patrick. I appreciate it.
Okay, take care.